Thank you, Larry, for accepting to introduce this very new recovery mentor training module at the University of Montreal.
It's my pleasure. I'm very excited about this project.
So am I, but I'm a bit worried. I want to do this the right way, to explain, to discover with the future recovery mentors what recovery is, what mentorship can be. I don't have all that knowledge. I'm here to discover in a participatory manner. So I was hoping you'd help me to start on the right foot.
Okay.
So basically we are talking to people who had a long history as consumers in the system, and they would like to help other people like them to get better. So how do we give some advice? How do we do that? Do we train? Do we teach recovery? What do you do here at Perch with people about recovery? You do. Let's talk about Perch maybe a little bit. You offer some training for professionals, and you do work with consumers as colleagues, right?
Yes, and we train consumers to be colleagues as well.
Okay.
Yes.
And how do you train people?
Well, there's a lot of content that we can get into after a bit, but I think the most important thing that we do from the very start is treat people with respect.
Respect.
We try to practice what we preach.
Okay.
And the fundamental value in a recovery approach is to respect people as human beings
Okay.
and to respect their dignity. So the first thing we do is treat people as people. And we try to convey to them that is a very important foundation for doing any kind of mentoring work with others, is to first and foremost respect them as individuals.
Okay.
That may sound obvious, it may sound simple, it may sound like something we should all be doing already, but it's particularly because of the unfortunate, you could actually say tragic, history of the mental health field that we have to convey to people the importance of treating people with dignity and respect, because we have a long history of not doing that. So long and so deep has that history been that it's really become taken for granted that you're not expected to treat people as people.
Yeah.
And service users, consumers, persons in recovery, and their loved ones who are going to be taking this course may unfortunately have experienced that firsthand.
Yeah, I heard some histories like that.
They may have been on the receiving end of disrespectful and dehumanizing attitudes, beliefs, and practices on the part of practitioners who, let's be clear, come into this field initially to help people. People become doctors, social workers, nurses, psychologists, most of the time out of genuine concern for others and a deep commitment to being helpful to them. But something happens, especially in the psychiatric field, something happens during the training process where that gets put on the shelf, and they learn to view people with mental illnesses and substance use disorders as different, and somehow less than human.
So then you provide some training to change things.
We help people to identify where those beliefs and prejudices may still lie, because sometimes they're very obvious, but sometimes they're not quite so obvious. And we also focus on the fact that unfortunately people in recovery will have at times internalized those same attitudes and beliefs themselves, which is one of the really pernicious aspects of stigma and discrimination. Stigmatized and discriminated populations internalize that view of themselves, and that's a primary, formidable barrier to recovery.
And do you work on this with?
We help people to identify how to identify when that's occurring and what to do about it. Okay. One thing that recovery mentors need to be prepared for if they're going to be working in medical settings is how to relate to their professional colleagues.
Yeah.
And we'll get into this more, but one of the most important things recovery mentors bring to their work is their own lived experience of both the mental health condition that they've had and their experiences of recovery, what they've done to learn how to take care of themselves and their condition, and how they can then share those lessons learned through the hard work of recovery with their mentees. But that's not what medical practitioners have been trained to do, and that's not something they're used to being exposed to. So this is a source of potential conflict between trained recovery mentors and their colleagues. Because they bring this lived experience perspective to the work, and they see things like that was a disrespectful encounter. This is somebody who's taking over responsibility for someone else's life and telling them what to do rather than asking them what they would like to do. Recovery mentors want to bring up these issues with their colleagues, and that can be a source of conflict.
I think it's in this paper that you suggest that people become people in recovery have to tell their own stories. Where is that paper? First, they have to be comfortable with the telling the stories.
Yes.
And then they see things in the system that might be disturbing for them.
That could even be re-traumatizing at times. Yes, that can remind them of the ways they were treated in the past.
Yeah. So you, what do you give them as a support training, for instance, for disclosing what is at stake there? Are anyone able to perform such a task?
Well, anyone can tell their own story. I think they need the permission to do so, because it's not something that they might have felt welcome to do in the past, because we've kept these things secret because they've been sources of shame, not sources of pride in one's own resilience and ability to overcome adversity, which is a very different way of looking at it. So they need to be invited to tell their story. They need to be given the message that their story is valuable, that things can be learned from their story, and that it is a story of resilience in the face of adversity, which shows their strength. So we train people to tell their recovery narratives from a strength-based perspective in terms of what did I do, what role did I play, what role did other people play in promoting my recovery. Not the war stories of how sick I was or how badly I was treated by others or the low points, but the climbing out of process.
For instance, our students might have work to do in the class to practice this capability of using one personal history.
It takes practice and coaching because, believe it or not, many people don't see that they played a role in their own recovery. Some of the initial narratives you'll hear is, well, I finally got a doctor who listened to me and put me on the right medication. As if that's all it took. And we know that medication may be important. I take medication myself. I would not want to have to do without it. I've tried a couple of times, didn't work. But I also know that I play a role on a day-to-day basis in maintaining and promoting my own recovery, and people have not necessarily looked at that themselves. They haven't taken pride in that. They haven't been able to reflect on the fact that they played an active role, or their loved ones played active roles in supporting them in ways that are equally as important as the medication.
So you must have seen some people who at first didn't see themselves as active recovery, leading their own recovery?
Most people see themselves more as having been passive victims. And not that they haven't been victimized, I'm not saying that hasn't happened, but what's more important and what other people can learn from is how they took that and channeled that into their own through their own agency into steps toward a better life.
So you know personally some people who went through this process?
Several, yes.
Several.
Many.
And what do you get from that, from your own personal perspective? You're a university professor?
Oh, I find it tremendously gratifying.
Yeah.
That's the best part of my work, is helping people to see the role they've played in their own lives, and to be able to support them in doing that more and more and more.
And you think that this could be is teachable? You can support someone to discover that he has always been an agent of his own recovery?
Yes, and there's a lot of what we clinicians call parallel process in the training of recovery mentors, because you do that by listening to the recovery mentor and helping them to identify their role, which is exactly what you want them to then be able to do with the people they're mentoring.
Yes.
So you treat them the way you would like them to treat the people they're mentoring, basically. And you show them what mentoring looks like in practice.
Okay. So if we were to do a class on recovery and respect and to show what can be to be a mentor, you would ask some people to share to talk about their experience in such a manner.
You might, if talking about mentoring, you might ask people first to identify a mentor they've had in their own lives and what they valued about that experience.
Okay.
Because again, that's a parallel process to looking back on your own life and what were the things you did that worked well that you can offer to your mentees as possible strategies.
Okay.
It's important to say early on in the process that just because something worked for you doesn't mean it's going to work for everybody else. So it's not that your path is the only path. So sometimes people need to be helped to understand that everybody has to find their own path, and a mentor's job is not to tell the people what to do, but it's to help them identify what they see as their next steps.
Okay.
So helping them to reflect on their own life experience is important, both in identifying the lessons they've learned, but also in identifying the junctures at which they could have gone different ways. And we'd like to say there are multiple pathways to recovery.
Yeah. And do you provide some tools for people to reflect on this? Do you have guidelines, some material? No?
Well, Sherelle may have some exercises.
Okay.
I don't.
Okay.
I am, what's the word? Predisposed against rote exercises. But
Okay.
I know they work.
Okay.
So ask Sherelle for that.
Okay, I will. So you suggested to me a number of papers because we want this to be evidence-based,
Yes.
right?
Yes.
One of them, the title is Recovery from Psychosis. What's Love Got to Do with It? Isn't that a song?
It's a Beatles. Well, it was inspired by a Beatles song.
Okay.
All You Need Is Love is the Beatles song.
Okay.
Inspired. So what's love got to do?
Yeah. Yeah. So,
Well, first let me comment on, what is it you just said that I wanted to comment on? Oh, evidence. There's a saying in the mental health consumer survivor movement in the United States, and there are even t-shirts that have been printed with this saying, which is omni-evidence.
oh yeah, I've seen that.
So the best evidence for recovery would be recovery mentors, because they are living proof of the possibility and reality of recovery.
It's a
So
great
that's,
responsibility.
it is a great responsibility. It's a great opportunity for the people they're mentoring to see in practice in life. It's inspiring of much hope and optimism. So it's important when we say evidence-based that we consider different types of evidence.
Yes.
Randomized controlled trials are not the only evidence of recovery, but seeing a recovery mentor on a day-to-day basis is very compelling evidence that recovery is possible.
Okay.
What's Love Got to Do with It paper, I was in, many people, once they get tenure as a professor, feel free to say and do things they weren't able to do prior to getting tenure. So when I got tenure, I celebrated by writing an article and giving a talk about love.
Ah,
That was my
lucky you.
coming out of the closet.
Okay, yeah.
And it was occasioned by Jan Olav Johansen, who's a very prominent psychiatrist in Norway who runs the TIPS program. It's a long-term early intervention program for young people with psychosis. It's been going on now for about 20 years. And he was organizing a conference around the Beatles because he's a Beatle maniac. He loves the Beatles, and he was organizing this international conference. And he picked the Beatles as the inspiration. So I picked All You Need Is Love as my inspiration. My daughter has that tattooed on her
Really?
side, my oldest daughter. All You Need Is Love. And I picked it because in my experience, the very first and most important thing that people who are struggling with psychosis or other serious mental illnesses need is compassion. And compassion comes out of love.
Okay.
There's no way to take a serious interest in someone who's suffering and to convey to them your serious interest in them and their welfare without doing it in a loving way. So by love, I do not mean erotic, romantic love. There are many forms of love.
Of course.
And in that particular paper, I go through a number of different forms of love. But the first one and the most important one was conveying a sense of respect for the personhood of the person with the condition. And what that means in lay terms is that you are not your illness. You are not a schizophrenic or a bipolar or a borderline. You are a person with schizophrenia or bipolar disorder or access to diagnosis or whatever the diagnosis may be. That is not who you are. And it's important, and Amy Johnson has taught me a lot about this, and she and I have written about this together in other papers that you could also look at if you wanted to pursue this further, about how it requires a loving stance to separate the person from the condition and the effects of the condition. Because mental illnesses make people say and do things that they wouldn't ordinarily choose to do. The illness can take over at times, and the person can be victimized first and foremost by the ravages of the illness. So it takes some compassion, active engagement, active compassion of engagement, to be able to find the person under the effects of the illness, and to be able to say, this is who you are, these things that are happening to you, that's not who you are, this is who you are. Amy talks about it as separating the forest from the trees, being able to see that the person is more than just the illness, and the illness is something that's happening to the person, not something they're actively choosing to undergo, and being able to take sides with that person so they can fight back against the illness. So I consider that to be more than just professional in the traditional sense, or in the conventional sense, actually. Traditionally, it may be more like what was meant by the term physician hundreds of years ago, but we've lost that to some degree. So it's beyond the technical interventions of mental health practitioners to take that kind of active, compassionate interest in who is the person here who I'm trying to be supportive of.
And you tell that to the person what you just said to me. You're a person.
You are not your illness. Yes, there is more to you than just your diagnosis. This is something that has happened to you. It's not something you brought on yourself. It's not something you're responsible for. Just like if you had cancer, we wouldn't blame you for having cancer. So in a lot of ways, it fits very well into a more general medical view, because mental illnesses have been considered illnesses for hundreds of years, but we still treat people like they're the ones at fault. And we still treat them as if they're responsible for their condition, which we might have done when cancer was stigmatized, but now that we accept that it's a medical condition, we don't blame people for having cancer. We don't blame people for having epilepsy. We used to blame people for having epilepsy. We will get to a day, I'm confident, maybe by the time my grandchildren come of age, that we will no longer blame people for having a mental illness. But right now, that requires an active pushing back against the history of the field, which has unfortunately perpetuated that view and discriminated against people with mental illnesses, at least since the the Great Confinement of the 17th century.
And in this paper, what's left got to do with it? You mentioned the SAMHSA document about recovery, particularly self-directed and person-centered.
Yes.
Is it to say that we were just mentioning, it's not, let's not do victim blaming, but isn't it only the person that is responsible for his or her recovery?
It's certainly not only the person. It's not only the person who's responsible for his or her recovery, but people do play an active role. And we accentuate and emphasize that because that has not been the accepted wisdom. The conventional wisdom was, you are a patient, you will do what I tell you, you will take these medications, and you will go home and sit on your couch and watch TV and smoke cigarettes.
Or a rocking chair.
Or a rocking chair, whatever.
Luc Vigneault in Quebec mentioned his life on a rocking chair. It's terrible.
These are culture-bound phenomena we're talking about. So in the U.S., you sit on your couch and you watch TV and you smoke cigarettes. And that's because people have been told there's nothing they can do. And until their brain chemicals are balanced, because after all it's a chemical imbalance, so until their brains are balanced, there's really not much they can do. Pat Deegan, who's an American spokesperson, consumer person in recovery and a psychologist, talks about the myth of chemical balance. That there's no such thing as chemicals being balanced in the brain, and if you wait for that, your life goes by. So we emphasize the person's role in recovery because we feel that's been overlooked in the past and people have been told that there's nothing they can do. So it's very important to educate and empower people that there are things they can do. They're not responsible for having the condition, but there are things they can do to take care of themselves in the face of the condition.
And this is the self-directed part.
I'll get to that.
Okay.
There are things they can do to minimize the effects of the condition, to manage the effects of the condition, and eventually to recover from the condition. So in Western democracies, like in Canada and in the US, self-direction is important because we believe in autonomy and personal sovereignty as basic fundamental rights of citizenship.
Right.
As we've worked on translating recovery into Chinese, for example, there are very different cultural values and worldview in Asia that do not accentuate self-direction as much. So that would be another conversation. But let's stick with the Western democracies for now. Why is self-direction important? Because adults who do not have mental illnesses are considered to be in charge of their own lives. And they can do or not do what doctors tell them. They have that right. And there's informed decision-making, informed consent, shared decision-making now, or what are patient partners, as it's being called in the French-speaking world. Adults are expected and have the right to expect to play an active role in their own medical care decision-making. That right has been denied to people with serious mental illnesses, not just in hospitals, although there were horrendous hundreds of years of people in hospitals who had no rights at all. And there are still some people living in hospitals whose rights have been denied to them. But for the most part, most adults with serious mental illnesses are not living in hospitals anymore. They're living in the community. And most of them are not so disabled that they have lost legally the right to their self-determination. So talking about self-direction is a way of honoring their fundamental right of citizenship to be a self-directed, autonomous human being. That doesn't mean that they don't need other people. We all need other people. I couldn't function a day without my wife. And I have a program here of 30-some people who I rely on a day-to-day basis to get our work done. None of us can function solely as an individual. But it's to restore the person's role as decision maker in his or her own life. Person-centered care, which is very much related to self-directed, doesn't put as much of a focus on the decision-making part. What it says is there's more to recovering from a serious mental illness than just getting rid of your symptoms. For 30, 40, 50 years now, maybe in the US, equally probably in Canada, the goal of the community mental health system was to keep people out of the hospital. That's not a life. So recovery is saying you have the right to have a life in the community, not just to stay out of a hospital. But now that you're in the community, you have a right to participate in the community, you have the right to a life in the community. We would like to help you have the kind of life you would like to lead. You should be the architect of what that life looks like. Again, you're not responsible for doing everything. You still need other people to support you, to help you to do certain things that you may not be able to do because of your illness. And we can get to that too at some point, what those might look like. But you at least have the right to tell us what your hopes, dreams, and aspirations for your life are, and that should guide your treatment plan. Your treatment plan should not be focused totally on getting rid of your symptoms, because we can't do that. For the first reason is we don't have a cure for serious mental illness. If we did, we wouldn't be having this discussion. But since we don't have a cure for serious mental illness, and since we're limited in what we can do to reduce symptoms, treatment plans should go beyond reducing symptoms to helping the person have the kind of life they want to lead. And that's called a person-centered care plan or a person-centered recovery plan. How much decision-making authority the person has in that process depends in part on the laws of the country that you were talking about and the legal parameters around impaired judgment and risk of harm to self or others. But outside of those fairly stringent legal parameters, both in the US and in Canada, adults have the right to make their own decisions.
And the recovery mentors, it might be a good idea for them to have some knowledge of these legal parameters.
It would be very important for them to have knowledge. It's not a lot of knowledge to have because the parameters are fairly stringent, as I said. If the person doesn't pose a serious risk to themselves or others, and if they would not, left unattended, basically die from neglect, they pretty much have the rest of their rights. So it's not a lot to learn. But it's important to know that a judge can determine someone incompetent to take care of themselves. But if a judge hasn't done that, a psychiatrist is not in the position to say that you can or cannot make your own decisions. It's important for recovery mentors to understand that, and they play a very important role in care planning meetings, for example, in helping the person advocate for their own perspective. Because we know just because you have a right to something doesn't mean you're going to get it on a day-to-day basis. but a very important role recovery mentors can play is helping the person figure out what kind of life they want and then to advocate for that to be the driving force behind the care plan.
Okay.
And they've been very effective in doing that in treatment planning team meetings, where their role has been to be the advocate for the person's perspective, when that person may not feel comfortable or capable of articulating it themselves.
And they can, I guess, support the person to identify the resources in the community on which they can rely on, if, of course, they cannot do everything by themselves and complete autonomy.
Yes, another very important role for a recovery mentor is to help people identify what those resources might be, to locate them in the local community, and to connect them to those resources. So if I really want to bowl, if I like bowling, I don't know how big a habit or a pastime that is in Montreal, but if I just say I like to bowl, a recovery mentor would be someone who might initially bowl with me, but then might also start looking for, are there leagues that I could join where I would feel comfortable that are not just other service users, but they're there because they're bowlers. Can the recovery mentor help me become a bowler? So I'm not just a mental patient or a service user, but now I'm also a bowler.
So it's quite a complex, the role of a recovery mentor.
It can be.
Or towards professionals to support the individual expressing his interests, hopes, and direction.
We hope that recovery mentors will take up roles in systems where practitioners are changing their practice to become more person-centered and more promotive of self-direction. Yeah. So we hope that all of this is in concert. But the reality is that recovery mentors often run up against significant obstacles to doing this kind of work.
Really?
Because of the attitudes of their colleagues. And that's an issue for supervision.
Do you have an example where attitude is an obstacle to...
well, the main attitude is being disrespectful and ignoring the person's own personhood. And that happens all the time. But let's just say there's a care planning meeting in which the person is going to be leaving the hospital, and the discussion is what will she be doing when she's out of the hospital. And I'm not blaming physicians, because it's an equal opportunity for disrespect across disciplines. But the psychiatrist is often the one in the position of chairing the meeting and saying, she has an appointment with so-and-so for Tuesday at 3. I've given her enough medication to last her until that appointment. She's set. And then someone needs to be saying, and hopefully Shirley, let's say the woman is Shirley. Shirley should be in the room, hopefully, as well. But let's say Shirley doesn't say anything. The recovery mentor might say, well, what else, Shirley? What else would you like to be doing when you're not at your appointment with your psychiatrist?
Maybe you have some other interest in life?
Maybe you have. Hopefully Shirley would have had this discussion with her mentor before the meeting so that they're prepared. But let's say they get in the meeting and they've had that discussion, and the mentor says, well, Shirley had been talking to me about knitting and how she really enjoys knitting, and maybe it would be great for her if she could find a knitting circle to join. 2. And the psychiatrist might say, well, no, let's take it a step at a time. That might be too stressful for Shirley.
Knitting, too
it's
stressful.
Possible. It's possible.
Yes, I tried once.
It can be very stressful. Yes. That's an opportunity for intervention. And the recovery mentor might say, well, actually, Shirley told me she would like to do that. I think Shirley deserves the opportunity and the chance to try it and see what might happen. Hopefully other practitioners, including the psychiatrist, him or herself, might then say, oh, that sounds like a really good idea, blah, blah, blah. But you could imagine if it was, I want a job, or I want my own apartment, or there are lots of opportunities for recovery mentors, or there are lots of situations in which recovery mentors will find themselves where this team wants not to rock the boat, wants Shirley just to take her medicine and avoid stress because it could precipitate relapse. And the recovery mentor and Shirley know that that's not recovery and that that's not sustainable, that you can't just take your medicine, go to one psychiatrist appointment a month and do nothing and expect to get better. So it's bringing up those things of what can Shirley do for herself, and what roles can other people play in Shirley's life to make it a richer, better life, more meaningful life, in addition to taking the medication.
But I suppose the recovery mentors has to be prepared to face some adversity,
It's an important focus of the training is how first not to take it personally, and how not to personalize it in the other person either, not to blame the psychiatrist for being patronizing or disrespectful. It's a system of care that all of these players work in, and it's appealing to people's better natures and being strength-based as much as possible. And as I said initially, it's really a very much important focus for supervision, how to deal with those instances.
And do we need to prepare the team, the professionals? How?
We strongly encourage any organization that's going to be hiring peer recovery mentors to have an organizational assessment and their own transformation process at the same time, because these issues will come up inevitably in systems that are not embracing recovery across the board. You cannot embrace recovery just by hiring recovery mentors. It requires a transformation of the organizational culture.
You wrote about this. Some organizations are convinced that they are already doing recovery.
Yes,
right?
that's been the major obstacle to doing recovery, to transforming services and systems over the last 20-some years, is this notion that we do it already. Yeah. It's very difficult, especially when you talk about things like respect, dignity, personhood. Nobody's going to say, oh yes, I treat people as other than human beings, or oh yes, I'm disrespectful. No, but nobody's going to want to see themselves that way. So it's taken a lot of work on my part and on the part of Maria O'Connell and some of the other faculty and staff here at Perch to help to operationalize what recovery looks like in practice, so that we can point to things and say, was Shirley in the care planning meeting? Was Shirley asked what she would like to do during the day? These kinds of questions. We have tools for this. I know we do have tools.
We do.
Yes. We have the recovery self-assessment, which is for organizations that want to transform to recovery, to identify where are the areas in which we need to change our practice to become more recovery-oriented.
We have this tool in French.
Yes.
And how could you say what is recovery, what is recovery is not, in a few words? Because
it's confusing because there's many different meanings to the term in English. I imagine there might be in French as well. Mostly in medical settings, including psychiatry, recovery usually means you got over an illness or an injury. You recovered.
You're cured.
You're cured, basically, right? Even if it's a broken leg, it's repaired, it's restored, you're back to normal, back to pre-morbid condition, whatever. And there is that sense in psychiatry, although it's been ignored for many years. But there's been data back going to Pinnell in the 18th century, showing that many people experiencing an episode of serious mental illness will recover fully from the episode over time. So there is that sense. Yes, he did use that word. He actually thought that 90% of his patients we saw within a year of the onset of their condition, who had not been treated badly before that by other practitioners, would recover over time. And there's been lots of studies since then that show that, in fact, many people do recover over time. So that's one meaning of recovery. The more recent meaning of recovery, which came from service users, consumers themselves, starting in the 1970s, although Pat Deegan was really the one to express this poignantly and compellingly in 1988 was the first time I've been able to find that it was written down. Is more of living a full life in the face of an ongoing mental illness or substance use disorder. And we need a word for that because the assumption was that you couldn't have a full and meaningful life if you had a mental illness. Not until you were cured, not until you recovered, would you be able to go back to having a good life. And Pat, who was diagnosed with schizophrenia when she was 17 and who went on to become a clinical psychologist and now an international leader of the service user movement, said, no, I still have my mental illness. I still take medication, but I have a hell of a life, thank you very much. And that's possible for everybody. Everybody should be afforded the opportunity and the resources to have a meaningful, full, productive, gratifying life, even when they might still be experiencing mental illness. And that's the more revolutionary notion of recovery.
Yes.
Because it says you still have the right to have a life. Just keeping you out of the hospital is not what a good life would be for you. You have the right to a good life in the Aristotelian sense.
You have to pursue happiness.
You have the right to pursue your own personal form of happiness. That's right. Even if that means knitting. You have the right
Or
to
bowling.
join a knitting circle or a bowling league or whatever will give you satisfaction, a sense of meaning and purpose and gratification. You have a right to pursue that.
Okay.
And we are here to support you in doing that. We're not just here to treat your symptoms, but we're here to help you have access to those activities, those opportunities, those experiences that you would value.
It's important to have good clinicians for good treatment if needed. But the recovery mentor, maybe his role is right there at the interface with the community. Where do you go?
That is
knitting?
one role for recovery mentors, yes. So the hospital role is very difficult for a recovery mentor because of the hierarchy and all of the severity of the illness and the acuity and all that. But recovery mentors working in community settings, that is an important part of their role, is interfacing with the community and helping people find those activities and experiences that they would value, and then helping them, if they're not the support that they need themselves, helping them get the supports they need. So if I want a job, for example, the recovery mentor would not necessarily be my job coach, but they would help me access a supported employment program where I could get a job coach.
And the university can be seen as a community also.
It is a part of the community, absolutely.
Yeah. And
Going back to school is a very important thing that people need support for. And more colleges, universities, and particularly community colleges in the U.S. Are starting to have disability resource offices that include mental health supports. It's a big change in the academic community that we have students now who have mental illnesses who are in school. They're not just kicked out and told to come back when they're better, but they're in school with supports.
So that's the basic idea for our teammates, recovery trainees, to provide the support among each other. And within the university, the Faculty of Medicine actually. And data shows that there is a lot of mental health problems among psychiatrists as well as medical students.
Well, we're learning as more and more people who acknowledge having a mental illness are showing up on college campuses and in graduate programs and medical schools. We're learning that there have always been people who are doctors and lawyers and Indian chiefs and who have had mental illnesses. They've just kept them secret, which has not done anybody any good, because it conveys the message that if you have a mental illness, you can't be a doctor or a lawyer or an accountant or whatever you want to be, and that's not true. It's just that there have been people doing that who have not disclosed.
So that's why they are most welcome to attend our classes and are not judging anyone. It's probably very suffering for some professionals to...
Oh, it's a tremendous relief when they're able to come out of the attic, as we call it. They're not coming out of the closet, they're coming out of the attic where people with mental illness used to be kept. And it's a tremendous relief. It doesn't mean it's not without its costs, because there is still stigma, and they might still face stigma. But on the other hand, they can be truly who they are and can be role models for others.
Great. Maybe do you have a final word or?
Well, you have the Health Affairs article is an important one. One of the ones I gave you because, first of all, it appears in Health Affairs, which is the most influential policy journal in the U.S. in terms of health affairs.
Okay.
As an emerging trend, although I think after 30 years it deserves to be more than emerging, but from their perspective it's an emerging trend. And in that article we articulate the disability rights perspective, which is very much connected to what we were just talking about. So an analogy I like to use, which I hope is helpful to some people, is if unfortunately someone loses use of their legs due to a car accident or a neurological condition or something, and they're taught how to use a wheelchair. And they use a wheelchair because we've cut curbs and sidewalks, and we've created larger doorways, and we have handicap access in many ways now that we didn't have prior to the 1970s, when the first law was passed that mandated access for people with disabilities in 1973 in the U.S.